And I just wanted to start out a little bit and ask Claudia if she could elaborate a little bit on L-arginine and wound healing, because I think that you really sort of ripped through that at the end, and I'd like to hear you sort of tell us a little bit more.
Okay. Well, so most of my research is focused on sickle cell disease. So the wound healing and trauma is sort of a relatively new interest that was generated definitely by interactions I've had with Juana Choa over the years. I think what we know from adults is that in particular, I think surgery is where the evidence is strongest for arginine-fortified formulas, that there was decreased mortality, morbidity in patients who were fed arginine-fortified formulas. There really isn't a lot of data in children, and what Juan had told me over the years is that even though he did these studies very meticulously, it was really hard to get surgeons to embrace this sort of nutritional intervention. And so my philosophy was that pediatricians are kinder and gentler. Maybe we would have, better success. But there really hasn't been done anything yet. I'm actively trying to seek funding to actually carry that through. So not a lot to say.
Do we have any questions from the audience for any of our speakers? And there they go to the microphones.
Can I just make one comment
Yes.
about wound healing, though? And I think that this is important as far as the pathway of arginase. I mean,
Yes.
Proline and these are part of the pathways that are rate limiting in collagen deposition. So too much of a good thing is bad. However, this is an important pathway. Arginase is an important pathway in wound healing. So even in my work with sickle cell disease, I've always been moving forward very cautiously because I'm concerned about, I think that it makes sense to think about therapeutics that involve arginase inhibitors, but you have to be so careful when you're inhibiting an enzyme that's so important. I mean, like so many of the mouse models, the animals all died when they didn't make arginase 1 or arginase 2. So I think it's something that we need to be careful of. But when you have arginase in the plasma, it's not supposed to be there. So if there's a way to get it out of the plasma, as opposed to arginase in the cell, you have to be very careful when arginase inhibitors get into the cell.
University of Wisconsin-Madison. I have a question for Claudia. With respect to sickle cell disease, you mentioned that the FDA approved glutamine to treat sickle cell disease. And I wondered how much of the glutamine efficacy is working through arginine.
I didn't plant you. That's a perfect question. I think a lot of the concern from hematologists who are not as excited as I would have liked them to be that glutamine, this is the first FDA-approved therapy for children and only the second for adults with sickle cell disease. But it's a nutritional therapy, so again, it seems like excitement has been dampened over that. One of the complaints is that they don't know how it works. And there are a number of pathways, including decreasing oxidative stress through NADPH that would make sense for sickle cell disease, but it also makes sense that it's an arginine prodrug, and we have 20 years worth of data to show that there's an arginine deficiency and that we're able to reverse it and improve outcomes in pulmonary hypertension in patients who have acute pain. So my bias is that it is also working through arginine, although I think that there's probably a number of different mechanisms. I also do have some data that I haven't published yet, but that's on my list for the year, where we did pharmacokinetics and we gave oral glutamine and showed that, in fact, you had a significant increase in arginine bioavailability from a single dose of oral glutamine. So it does get converted, at least in sickle cell disease, to improving your arginine bioavailability, both in plasma and within the red blood cell.
My impression on the arginine supplementation is that a lot of the clinicians are afraid of it because of sepsis and the negative consequences of arginine in that condition. Any thoughts on that?
Well, I think that there's reason to be concerned because of the sepsis studies. But I think you also have to think about your patient population. When we're talking about sickle cell disease, I mean, arginine is actually incredibly safe. Mm-hmm. And most of our patients, fortunately, aren't septic, but they are arginine deficient. But the other thing that's really interesting about sickle cell disease is how they metabolize arginine varies based on age. So the adults are arginine deficient at baseline, whereas the kids are not. They develop an arginine deficiency over time. If you give an arginine supplementation, and this was oral pharmacokinetics work that we published in, I think, 2000, you actually had a paradoxical decrease in nitric oxide metabolites, which was, we were all kind of scratching our head. We didn't understand the role of arginase and ADMA at the time, but when you actually brought the same patient back when they were having an acute pain crisis, when their arginine levels dropped even further, we were actually able to increase their nitric oxide metabolite. So sickle cell patients metabolize arginine different than normal controls. If you give a normal person arginine, their nitric oxide levels go up, and you can measure that within 2 hours. That's not the case with sickle cell, but when they're in an acute crisis, they have low arginine and nitric oxide levels from, say, pulmonary hypertension, their physiology appears to be different, which makes it really complicated because you can't put all the sickle cell patients in one basket.
Right. So it illustrates the effect of conditionally essential nutrients, in this case arginine, in different metabolic states, very, very clearly. What you
Absolutely.
described. Thank you.
Barbara?
Barbara Schneeman. So, we're missing one presentation, so
Yeah.
I'm going to hope I can maybe prevail on Angus and Claudia to sort of think about some of the topics that were in the presentation about hypermetabolic states, especially burns and surgery. And certainly I know that there is some literature about arginine and surgery recovery, so I'm hoping maybe you might have some comments about that. And Angus, I don't know if you're strictly focused on the brain or if your work at DOD extends into thinking about how nutrients can help in recovery from surgery or for burns, other traumas that soldiers might encounter.
Well, actually, I'll be redirecting it towards you. I actually did have a question for you about, the omega-3s and traumatic brain injury, because there is some data out there that shows if you actually give omega-3s and arginine that you get these nitrosylated fatty acids that have some, that can get past the blood-brain barrier and have some neuroprotective. And have you guys looked at any combinations that utilize arginine?
So we work with the Norwegian Army, and we get a drink called Smartfish from Oslo. It has 1,000 milligrams of EPA, 1,000 milligrams of DHA, and it has vitamin D in it, and the rats readily drink it. And we've done studies in soldiers you start giving them a chocolate granola bar on Monday, by Thursday they don't want to eat chocolate anymore. So we are very careful about what's in it. It's clementine, it's apple, and it's pear, and the rats will consume it for 60 days with no concern. So we have a very effective delivery to get DHA and EPA and vitamin D into the rats. Concerning your question, in a football injury, the injury is restricted to the brain and the shaking and the coup, contra coup, whiplash in the head only. We find that in BLAST, the microbiome studies we've done in the feces, in the fecal material with blood in it, that there is gut leakage as well in the gut. So then an idea to add first would be something like a single shot of glutamine to repair the gut, because even if you came with Ben and Jerry's and said this was magic, it wouldn't be absorbed. So we need to treat the gut that's been disrupted by the blast before we come in with our combination or single anything. So blast TBI, in our view, blast TBI is quite different from non-blast TBI. Did that answer your question?
Yeah, well, it sort of gives a
So
different
ma'am,
way of thinking of it.
soldiers get burnt a lot.
Uh-huh.
And the people in San Antonio are dealing with that, but none of it is, and the animal models are horrible, and none of it is nutritional interventions. Zinc is leached out in the burn exudate. There is zinc in that. So I've approached them to see if they could do zinc supplements in burnt animals, burnt soldiers, but we haven't got that far.
Just one more thing. When I actually started looking into this phenomenon of not feeding the children in the ICU, then I actually wanted to determine what was it that they were actually getting NG fed when they did start to feed them. And when I looked at the ingredients of some of these formulas, it was like high fructose corn syrup was the first ingredient. And you'd mentioned, high glucose levels and insulin and all that. So maybe they're right. You're better off not feeding for a week than feeding a formula that's high fructose corn syrup. And I think we really need to consider what is actually in the formula and how do we deliver better protein and better sources of carbohydrates than high fructose corn syrup.
Thank you.
Patrick?
This is Patrick Stover, Texas A&M. My question is for Dr. Scrimgeour. You mentioned that in cases of TBI that the rodent models really don't recapitulate or the findings from those in human studies. Do you know the reason for this, why that model is limited?
There are multiple reasons. So, we've picked the rodent model because it's what everyone else has been doing. So I can do comparative studies at 18,000 manuscripts on rat TBI with a lysencephalic brain, meaning smooth brain surface, and that's quite different. The lowest order gyrencephalic or rutted brain is the ferret, and I don't have antibodies to ferret neural GFAP or markers in ferret brains. And without being flippant, soldiers won't volunteer for my studies. So I don't get any of them. So in the rat, when I've got a pretty flat forehead, and when we orientate the rat to face the blast, it's a different thickness of the skull. We don't use a rat that's below 350 grams because it's possibly more cartilaginous brain. It'll just bend and go back up. So we use an old guy's brain. He has to be above 400 grams. There are multiple concerns about translating the findings in rat to the human, particularly in the drug studies. There's a big lab at Walter Reed in Silver Springs where every year a new postdoc comes in the lab and they get a new drug, and they have very good success in drug studies repairing cognitive deficits as well as biochemical repair in the rat model. And 0 have translated into the soldier. It's only been 3 months ago that was in the New York Times that the drug company now has come out with a on the side of the field test looking at 2 biomarkers for TBI. So as you're well aware, we don't have a good feel for how much damage, never mind is nutrition going to repair those biomarkers. Did that answer your question?
Gary?
Gary Wu, University of Pennsylvania. So Agnes, I can just hear the frustration in your voice. I totally understand what you're saying, and this is not just for TBI. I work in the area of inflammatory bowel disease. Animal models of inflammatory bowel disease are absolutely terrible prognostic markers of therapeutics in human biology, which does mean that at some point you have to study humans. My notion is, and I'm wondering about your notion about this, well, perhaps it's because our technologies and trying to understand the biochemistry of the brain are not that sophisticated right now. When you look at CT scans, for example, looking at traumatic brain injury, I'm just wondering if there's hope on the horizon, like, newer types of technologies, 7T magnets now that are being using for fMRI, actually doing spectral imaging of the brain, beginning to understand the biochemistry of the brain. Maybe those types of technologies can be applied to TBI to actually understand how the brain is metabolically responding to traumatic brain injury. Maybe that's one way forward. I don't know if you have comments on that.
Only to say that with the CTE, chronic traumatic encephalopathy, out of the Boston University group with Ann McGee and Lee Goldstein's group, they've now got a marker which is great, but it can only be done after death. So we don't even have them, that's football injuries, and they've got this brain bank where they're looking at a panoply of different diseases and brain injury, and we don't even have a marker in a living athlete, never mind a soldier. A lot of the money has been spent on suicide prevention in these soldiers, on diagnosing the soldiers, doing the ANAMs and the different testing and that, and we're away from translating our animal findings to humans. It's a big gap, and it's frustrating as well.
Yeah, I think that my personal opinion is that some of this is going to be technology driven. I mean, I work in a microbiome space, and that's how, that's why you hear about the microbiome so much, is DNA sequencing technology. I just think that brain imaging technology and a lot of effort and going into neuroscience right now may, in real time, allow you to understand the human brain while people are still alive in ways that we don't understand right now, but that's a hope, I guess.
Is there any role, so there are folks approaching us in the emergency department to do these bedside EEGs on the soccer field in the emergency department. Is there any role for that on the field for soldiers?
The answer is yes. I don't know where it fits in. So we're on the preventative medicine side, combat casualties, post-trauma, and we were directed not to even focus on nutrition interventions for combat casualty care. It's fortunate for me in my animal models, I can say I need to study them in repair to tell me if the stuff prophylactically worked. So we tell white lies to get around that, but I do not. Of course, I think there's a place for this on the sideline, and if the pathophysiology is similar to the football injuries, as I said, then perhaps the nutrition interventions of pharma could translate to both soldiers and to the athlete.
Do we have any additional questions? I want to thank our panel very much. Barbara, do you have any words of wisdom for us for tomorrow?
Well, that concludes today. And so tomorrow the program begins. We'll be back in the same room, but registration is between 7:30 and 8:30. So the first session will begin tomorrow morning at 8:30, and I look forward to seeing you all then.